My name is Sindhu Ravishankar. I am the Vice President of Programs and Research at the Fast Track Cities Institute and IAPAC, the International Association of Providers of AIDS Care. Really wonderful to virtually be here with everyone today and speak to you about epidemic control targets. So really the kind of reason around the subject matter is because there's a need to build consensus around epidemic control targets. We know that target setting is really, really important and also really effective. We know that the 95-95-95 targets are really important for getting to zero new infections and zero HIV-related deaths. And we've also seen that achieving 95-95-95 on its own is not necessarily sufficient when we're really talking about zero new infections and zero HIV-related deaths. This is where epidemic control comes in, because epidemic control more holistically looks at both treatment and prevention, and essentially how these two are married and has an impact on both incidence and mortality. We were successful in treatment through the 95-95-95 targets. We've seen that many cities and countries have reached 90-90-90. But prevention is more than just an adjunct in epidemic control. Prevention and treatment really go hand in hand. And this is what epidemic control and looking at epidemic control additionally brings to the table. So it's not at all to say that 95-95-95 is not relevant. It is very relevant and it's very important. But when we're advocating for strategies to get to zero, whether it be zero new HIV infections or zero HIV-related deaths, we really need to be able to back it up with the data on the impact of both treatment and prevention on epidemic control. And so that's why, I chose this topic today to speak about what is epidemic control, what are the targets that exist, and what are some of the next steps that we need to really think about if we're trying to come together under global consensus and really define set targets for epidemic control. So HIV epidemic control measures exist. This in itself is not at all a new concept. These indicators or targets that I'll discuss is nothing that I'm, novelly creating. This is all already available in the literature. So I want to make that very clear because I'm borrowing from concepts that have been published already. But there is a need to democratize the concept of epidemic control and the targets and indicators relevant to epidemic control. And there's a need to provide the tools to measure epidemic control progress at both global, national, and subnational levels, as well as in subpopulations. So with specific key populations, different age bands, gender, race, and ethnicity. And there's no singular measure of epidemic control that the global community has really come to consensus around in the same way that there has been consensus building, for example, around 95-95-95. One example, however, where there has been some global standardization of epidemic control is in PEPFAR's strategy for accelerating HIV/AIDS epidemic control from 2017 to 2020. And PEPFAR defines epidemic control as being reached when the total number of new HIV infections falls below the total number of deaths from all causes among HIV-infected individuals. And just based on the rollout of this target in 13 high-burden countries in PEPFAR, and it's only been done at national level, we already see the successes in that 10 of the 13 countries have reached this global target of what we call the incidence mortality rate of being less than 1. Essentially, that is that the mortality is higher than the incidence. PEPFAR also has been routinely collecting incidence prevalence rate data, and 3 of the 13 countries have met this target. And they've also been considering collecting incidence rate, so incidence per 1,000 population, and 8 of the 13 countries have met this global target, and the global target being less than 1 per 1,000 per population. So we see that even when we're looking at these 3 targets, all of which have an impact on epidemic control, the fact that the IMR has been defined as the epidemic control target could have really contributed to the success, given that more countries have actually met this target. So again, it's the 10 out of the 13 countries that have met this target. So we clearly see the success of global target setting. We talked about the 90-90-90 and the 95-95-95 targets that have been really widely adopted and very successful in, putting focus on the scale up of ART and viral suppression. And there have been other initiatives in the past as well. So there's the 3x5 initiative. This one was aiming to treat 3 million people in LMIC's low and middle income countries by 2005. So this target was met slightly delayed, but it was still met. And I think a lot of credit to reaching the target was kind of the global consensus around setting this target. And then there was the 15x15, which aimed to reach 15 million people with ART by 2015. This actually surpassed the targeted timeline. Again, speaks to the importance of target setting. So really, this is just setting the stage to say, in summary, that we need to consider epidemic control, because epidemic control looks both at treatment, prevention, marries the two, and sees how it has an impact on incidence and mortality. And this is really key when we're trying to look at getting to zero infections and zero HIV-related deaths. And then the second part of the summary of this context is that we see that global target setting is really important in building consensus and really working towards measuring, monitoring, and reporting targets. So without consensus around global targets, people are not collecting these data, that we're not measuring the targets. It's harder to kind of enforce and really track how we're doing with regards to epidemic control. So the second piece, what I want to discuss with you all, is what we currently have when we're thinking about epidemic control. So the first kind of subset of measures I'll speak about is incidence rate and mortality rate. So incidence rate essentially is the number of new infections per 1,000 population. We do have a Sustainable Development Goal target of an incidence rate of 1 per 1,000 population, so 1 new infection per 1,000 population, and this was proposed to monitor the Sustainable Development Goal target. But the limitation to this is it needs to be considered in terms of population growth, because it's possible for the incidence rate to decrease if the population is increasing. Similarly, we also have mortality rate, which is the number of AIDS-related deaths per 1,000 population. This also is susceptible to population growth. But the good things about these two measures is that they are easy to measure. It's very simple metrics, simple methodology, and it can be disaggregated. It can be applied in national, subnational, and global contexts, and it can also be disaggregated by subpopulation. So we can kind of see some of those subpopulation trajectories and really see where some of the subpopulations might be falling through the cracks, whether it's key populations, populations of different ages, genders, races, or race or ethnicities. The downsides, though, when we're considering incidence rate or mortality rate in terms of a global target, is that these targets need to be set to relevant local context. So even though there is a SDG target of one new infection per 1,000 population, actually a lot of countries have actually already met this, and what that incidence rate and what the mortality rate is should really look into the context of each country and each city. And then the second thing is these targets may need to be continuously adapted to consider population dynamics. So the target itself it may need to be a moving target, especially when you're seeing population growth. And that's extremely relevant when we're looking at cities and urban contexts and migration and all of that. So the population dynamics also need to be considered, which might mean that the target is a moving target and is consistently changing. But again, it's easy to measure. It can be disaggregated by subpopulation, and it can also be relevant for national, subnational, and global contexts. The second subset of targets, epidemic control targets that we can think about are the incidence and mortality targets that were adopted at the 2016 UN high-level meeting. So the first of these related to new infections is the percent reduction in the number of new infections since 2010. And the target was for 75% reduction by the year 2020 and 90% reduction by the year 2030. Similarly, for mortality, it was on the percent reduction in AIDS-related deaths since 2010, with the target being 75% reduction by 2020 and 90% reduction by 2030. And the good thing about these targets is the targets themselves are used deriving a model that represents the impact on the epidemic of an array of treatment and prevention interventions. So the other kind of upside to this is that it's a global target. It's fixed. It's the 90%, 75% reduction by 2020, the 90% reduction by 2030. These targets are fixed, so it's easier when we're talking about building consensus around a target, and it is relatively simple to measure. And it's possible to calculate this target for global, national, and subnational contexts, as well as for different subpopulations. The limitation, however, for these targets is that the targets themselves, so the 75% reduction in incidence or mortality and the 90% reduction in incidence and mortality, these targets are based on a global model and a set of standard interventions and the impact that interventions have on epidemic control. So it doesn't actually take into the consideration of local contexts. Another limitation is that it does take into consideration the improvement since baseline. So, how has a country or a city improved in incidence and mortality changed since baseline 2010, but it doesn't look at the baseline itself. So, for example, it could be possible for a country or city to have a low reduction in incidence, but overall a low baseline incidence rate. So it doesn't really get at those nuances. So one option with these targets could be to consider them in the context of overall reduction in incidence and mortality rate per 1,000 population. So kind of the first subset of targets that we talked about. And then lastly, I just want to touch on two kind of newer metrics for epidemic control. They're less prevalently used, a little bit more complex, but perhaps gives us a little bit more information. So the first of these is the incidence prevalence rate. And this essentially is the ratio of new HIV infections to the number of people living with HIV. And the benchmark for this is that the incidence prevalence rate should be less than 0.03. And basically it's saying that there's a level of incidence that needs to be achieved for us to be seeing a shrink in epidemic over time. And so basically when the ratio of being below 0.03, or that when incidence prevalence ratio is below 0.03, the epidemic will decline. This is also important because it's based on epidemiological relevant shift in the epidemic. This benchmark, the less than 0.03, was chosen based on models that suggest that the average life expectancy of a person living with HIV is 33 years. So the strengths of this, again, as I mentioned, is that it does identify an epidemiological relevant shift where the epidemic is starting to shrink. It can be applied to all epidemics, regardless of the level of incidence and prevalence. So whether there's low levels of incidence and prevalence, high levels of incidence and prevalence, it's equally relevant, which is kind of different from what we saw when we were looking at the prior subset of targets that were looking at the percentage of reduction. So the other strength is that it applies to national, subnational, and global populations. But one of the limitations is that it cannot be applied to subpopulations. So key populations, age, gender, race, ethnicity, it's not kind of relevant. It's really looking at full population and the shift in the epidemic for the total population. Some of the other limitations is that because the benchmark is based on a life expectancy of people living with HIV, the life expectancy being 33 years, it doesn't really account for differences in life expectancies in different regions. And actually, in 2016, we saw that there was only one region that had reached this target, and that was US and Western Europe. And it's possible that the definition of the target around life expectancies could have had an impact on why that was the only region that was able to reach this target. So really need to consider it within the context of what is the life expectancy in the region or country that we're thinking about. And then the last thing that I'll discuss is the IMR, so the incidence mortality rate. And as of 2016, no region actually had achieved the IMR. The definition of the IMR is the ratio of new HIV infections to the total number of deaths among HIV population, and the benchmark would be less than 1. So we actually discussed this a little bit at the start of this talk. This is the same as PEPFAR's definition, that the incidence should be lower than the mortality. Apologies, that the mortality should be lower than incidence. So when this value is less than 1, the size of the population living with HIV decreases. So again, this shows an epidemiological shift and a shrinking of the epidemic. Some of the strengths of this is that it applies to epidemics of all sizes. So regardless of the level of incidence or prevalence, again, it's similar to kind of the IPR that we talked about. And it applies to global, national, and subnational populations. But again, it does not apply to subpopulations, so key populations, age, gender, race, ethnicity. Some of the other limitations is that it does need to be interpreted with other measures of low mortality or with measures of high coverage. And the reason for this is because the target of having the incidence mortality rate of less than 1 on its own doesn't actually require a reduction in mortality. And it's actually possible for the IMR to be less than 1, meaning that the target has been achieved, and still have a high level of mortality, because it's really just comparing the incidence and mortality. So you could have, still have high level of mortality. So really, to be able to implement this target, we need to look at additional targets that can be looked at in conjunction with the with the incidence mortality rate. And a couple of possible targets for this could be looking at the reduction of mortality among people living with HIV compared to mortality among HIV negative populations, or looking at it in conjunction with programmatic targets, so kind of looking at it in conjunction with ART coverage, for example. So when we're thinking about incidence prevalence rate and incidence mortality rate, there are some real strengths in these approaches, because they do go into some of the complexities. They're more focused on the epidemiological shift and how the epidemic is starting to shrink. And it's something that can be applied as a global target. There's not necessarily a need to contextualize the actual target based on the different regions. So these could be really important targets. But it needs to be taken into account with additional metrics. perhaps some of the other metrics that we've discussed in this talk. So I'll kind of close with a brief summary of what we discussed. Really, we need to think about three main things when we're looking at epidemic control. One is when we're looking at epidemic control indicators, we need to consider the accuracy of these indicators in measuring progress for epidemic control, and specifically thinking about epidemic control on the track to getting to zero new infections and zero AIDS-related deaths. Then we need to think about the strengths and limitations of each of these approaches, and specifically thinking about the applicability of it as a global target. So, it might be much easier to calculate a incidence rate or mortality rate, but when we're thinking about a global target, this becomes less, reasonable. And then finally, we need to think about how can we define guidance to implement epidemic control measurement globally. And this doesn't actually mean that we just need one metric. We saw that there are strengths and weaknesses in all the different kind of metrics. So how can we kind of piece together some of these metrics in a way that can really allow us to track progress towards epidemic control and progress towards getting to zero new infections and zero death, HIV-related deaths. And I'll conclude by saying that, this is truly important because we've seen the impact that target setting has had in other areas. So, for example, around expanding treatment coverage. So if our ultimate focus really is on getting zero HIV infections and zero HIV-related deaths, then it's going to be critical that we carefully think about how to democratize epidemic control measures and targets, and how do we track this globally, and how do we see the impact that the epidemic control targets have on reducing new infections and reducing HIV-related deaths. So just a lot to think about. I don't have any specific answers, but I think that the importance is very relevant. The context is there. So I hope that we can move this discussion forward and see how we can actually operationalize epidemic control measurement in globally, nationally, and subnationally. So with that, I'll wrap this up. Thank you so much for your time. It's been an absolute pleasure to address this virtual audience, and I look forward to what will come about in this space in the near future. Thanks again.